Hi, Jenna. Thank you so much for joining me. I can't wait to bring our guests up in just a minute, but I wanted to start with us today and just kind of just go down memory lane of how we started enhanced recovery after delivery and really
Yes.
why we started it. And I've been reflecting on this a lot. There was a study that hit home quite recently that was released in the same month that our paper for Physical Therapy Journal was released. And it was released this past August. And it was a study that was done on 1 million births in the state of New Jersey, my home state. And it revealed that Black women, just by the nature of the color of their skin, are 25% more likely to undergo a cesarean delivery. And I thought about back to 2020 when we first, as acute care therapists, started treating moms on the maternity unit, that a lot of that came out of just the scarcity of us needing to work, really. I mean, there were no jobs. A lot of clinics had shut down. As acute care therapists, we were basically told, you don't have to come into work or you could do temperature checks. But moms were still delivering by C-section,
This
right?
is
Like
true.
that
Yes.
was the surgery that was
Babies were
still done.
coming.
Babies were still being born.
hmm
And that at that time we were working in a hospital that was delivering 500 babies a month. And I think
Correct.
probably even a little bit more, to be honest with you, during COVID for sure, because of all the high risk pregnancies. We had mom coming in with COVID and being admitted to the ICU and then having emergency C-sections. And so that was really common at that time. And I thought to myself that this was the first time in my career that I treated as many women of color as a pelvic health therapist, first of all, and then in acute care. I had never treated in 5 years of practice that many women of color during just 1 year of practice alone, as I did when I worked in the hospital, treating them on the maternity unit after C-section. And
Mm.
so this study that was released about 1 million births to span the time that we were practicing, I'm just thinking of all the moms that had unnecessary C-sections at that time just because of the color of their skin. And I
Right.
realized that even though as physical therapists, occupational therapists, we are not there yet to change that. I think the disparity deepens even more when we send those moms home without a recovery plan,
Mm.
right?
Absolutely.
And I would love for you, I mean, we talked about this a bit with our team, but when we published this paper, we specifically titled it, right? The way that we
hmm
did in terms of talking about disparities in the acute care environment. And I would love to just like know your thoughts on that. Why do you think it was important that we titled it that way?
Well, one of the biggest, I think, areas that we wanted to drive home, yes, there are racial disparities, absolutely, but we also were seeing that this population in general was not receiving the same level of care that other populations were getting. So let's try to compare this as close to apples as we can and compare someone who's had a cesarean section, which we know is a major open abdominal surgery, to someone who's had another form of an abdominal surgery, whether it's an appendectomy, a gallbladder removal, hernia repair, all of these things. And acute care therapists, those that work in the hospital, very commonly work with individuals after these other types of abdominal surgeries. And we're asking all the questions about home environment, their support that they're going to have when they get home to make sure that they can perform their ADLs, that they're going to be able to get food, all of those things. How are they going to mobilize and get around? But yet this other population of individuals that if we're just looking at cesarean section and comparing it to these other abdominal surgeries, well, they have all of those same tasks to do as well, in addition to having to care for another life, um, potentially, of course. And so, why would we not be offering the services that we provide to these other abdominal surgeries and not to them as well, especially when we consider the mortality and morbidity that we have in the United States compared to other developed nations. It's just atrocious in the United States. We have the worst maternal health outcomes out of any nation, out of any country.
Right. Out of any high income nation, that's absolutely right.
Yes.
And and so you and I, we've worked in these, level one equivalent trauma centers. We've started with a team programs that now offered women after C-section the option of getting physical therapy before they left the hospital. Mm-hmm. But we did that in one or two hospitals. We did not do that across 12, right? And so our next guest that we're bringing up and talking to, I need to understand, one, how they were able to move so fast, because we did interview them last year, and how they were able to get that much buy-in. To me, that's just been incredible that they were able to expand access. And from what I understand, both occupational and physical therapy, we'll get them to kind of tell us the full story on that, or correct anything that we might have misunderstood. But I can't wait to speak to these professionals and just other professionals in the field that are recognizing that all of us have a role and reducing the disparities in maternal care, especially for those post-surgical populations who are getting access to rehab after a knee replacement, after a hip replacement, after a shoulder replacement. I remember walking around with patients with their arm in a sling to make sure they were safe to go home after their shoulder replacement, but yet walking into a room with a mom who was furniture walking, to keep her balance because she might have either hemorrhaged or had a C-section, and I still had to advocate for her to get orders to offer her rehab services. So without further ado, I would love to bring up Jasmine Dockett and Rachel Lewis. And please, will you introduce yourself, your system, and the work that you're doing? Welcome.
Thank you. Thank you. Yes, I'm Rachel Lewis. I'm an occupational therapist, and I'm the rehab manager.
And I'm Jasmine Dockett. I'm an occupational therapist here at Centura Hospital, but I also specialize in the NICU and now postpartum.
Mm-hmm. Excellent. And tell us a little bit about, first of all, how you got started with serving moms or providing occupational therapy, first and foremost, to moms that were admitted to the hospital before or after their birth.
Yeah, I guess this all started now 3 years ago, I guess, the idea. So like I said, I specialize in the NICU. So I was working with a mom in the NICU. She had twins. And as I was working with the baby, I saw mom was just struggling with just the normal tasks that she had to do. So getting up from her chair to attend to her baby, even picking up the baby to sit back down, just like your daily tasks that you're going to have interacting. And I just saw how difficult it was for the mom. So I just asked the mom a simple question. And I said, "How are you doing? How are you feeling?" And she kind of just bawled. And all of the emotions kind of came out. And she was just like, wow, no one has just asked me just a simple question. I've been in the NICU and I've been attending to my baby, but no one has asked me that question. Mm-hmm. So that kind of just got my wheels going. And I brought that attention to my manager at the time. And I told her what I found. And I was like, just like Jenna and Rebecca, you guys were talking about earlier, is we see patients that have other abdominal surgeries all the time. Mm-hmm. Why don't we see moms that have had a C-section, which is a major abdominal surgery? It's the number one surgery in acute care. And why don't we see this population? It's a huge population we're missing. Mm-hmm. So with my manager at the time, I was like, if you can tell me a why we shouldn't see this population, then you got me. Now, obviously, she couldn't tell me a why. So there was no reason why we shouldn't, right? And then our next step was to present it to our executive team. And from there, I thought I was just going to do my hospital, but their intention was like, oh, they loved it so much. They're like, no, we're going to do every hospital in our system. And I was like, oh, okay. I like where you're going. All right. So that's kind of how it all started. And then we just got a lot of buy-in from our executive team.
Okay, and then can you just remind us? You said I thought I read 12 hospitals. Is that correct?
Yes. It's now today is in 12 hospitals. It took time, but I actually recently just trained the last few hospitals, therapists, PT and OTs. So now they are equipped to go ahead and serve that population.
Okay, let's back up just a little bit. So like just take us back to that presentation or that pitch, if you will, to your administrator, because honestly, that's where a lot of people just stop. They're
Yes.
like, we didn't even get past the door. So you, in one presentation, they said, let's do it in all 12 hospitals.
Yes, it was so with our executive team, I will say it was women, so that might have an indication of it. And they've also have given birth before. So they kind of took their own experience and were like, wow, I wish I had a physical therapist or an occupational therapist when I gave birth. And it's like 20, 30 years ago, but they saw how much that was a need back then for them. And they just couldn't see why we wouldn't do that now for today's moms.
This is, I'm gonna just kind of like chat on the side with Jenna here a little bit, because she knows that I'm like consuming this negotiation book, and you usually want to actually get the no. You don't yes, because the no opens the door for an actual conversation. Like, why do you feel that way? You led with the why. Like, why not? So you were almost like preparing yourself for the no, but you
Yes.
went in and just said, I'm seeing this patient population. Why wouldn't we offer these services?
Right. And I feel like sometimes when you ask a question back to someone, it makes them think of whatever you're asking them, and that kind of sets the precedent of what is about to be talked about. I feel like sometimes when we're presenting all the time and we're kind of just telling them why, like what should happen, but when you get people to think about it for themselves, you might get a different reaction.
Wow. And Rachel, I want to ask you, and maybe, because your role has changed. Since we last spoke with you, last year about this. So were you kind of like, that therapist that said, yep, Jasmine, I love it, I'm on board. Were you like one of the first early adopters from a colleague standpoint for this program to start?
Yes, so when Jasmine did bring the idea, we did start with the two therapists, which happened to be Jasmine and myself. So then we came to your course when they had it in Norfolk, I believe, at the time. And I think one of the things that also made this program really great from the beginning is one, Jasmine came with the passion for this. Like, she has a passion for the patients and the patient care. And it's also something I also have. So when we came to the course, my wheels just started turning. I was like, we do need to do this. This is important. And Jasmine's passion and compassion for the patients spread on to me. And the great thing now that I've transitioned into this role and Jasmine has started expanding it to different places in our healthcare system, there's other passion from other therapists as well. They are so excited about this. They're excited about sharing it, touching a different population that we hadn't touched before. And it really gets to me to see how many people that are passionate about doing this. So
amazing. And Jenna, I'm just going to kind of put it aside to you, because a lot of therapists have asked us about like having a pelvic health or a women's health background. And you yourself, you don't have
I do not.
that kind of background. But I think in Jasmine's case, I thought there was maybe a clinical ladder, a specialist, or a designation, I thought, for women's.
Oh, yeah. I mean, it's a potential, but that's not what I started with.
Amazing. So all of you are acute care therapists.
Yeah, that's it.
Yeah.
That's it. I mean, Jasmine,
but it's
correct it there. And I'm going to let Jenna probably take this on, because I feel like acute care therapists are their own specialists.
Yeah.
We
Right.
need our own specialty, you know.
Mhm.
It
Yeah.
is such a unique practice area.
Mhm.
And it takes such a unique skill set too. It really does. But yeah, I would just have to agree with you, Rebecca, that I don't think a specific pelvic health designation is going to necessarily set you above and beyond what our acute care therapists already would know what to do, the questions to ask,
Mhm.
um, what to provide in terms of education and mobility assessments. So and I am not a pelvic health therapist. I have zero training in that area, formally, that is, at all. In fact, I'm actually a neuroclinical specialist, so it's but from I have lots of little passion areas, and I get frustrated, I guess, even though I have a specialty, I get frustrated when others feel like we have to stay in this narrow lane because this is now my specialty, whereas a human body has all of those different systems running through their body, and everything truly is connected. And so we can't forget about just all of our knowledge and skills that we have accumulated, whether it was through physical therapy school, occupational therapy school, clinical experiences, the research that we've read. All of that is really what helps to expand these services.
Yeah, totally agree. And guys, you've heard us say this probably. I've always tried to like prod Jenna along to just tell this case because when we moved from the first hospital that we were opening this discussion with, we moved to another hospital where Jenna encountered a woman who's the OBGYN was like, she doesn't need anything, doesn't need anything. And what we've kind of like decided to do is like, instead of us as physical therapists constantly talk about all the benefits of occupational therapists, we started to do more of case-based teaching and getting occupational therapists to talk about what they would do with this case. And so before we like continue and kind of like really get a sense of like, okay, how did you get other colleagues then to buy in? What was the story you told? What was the case that you told? I often ask Jenna if she could just share just a snippet of this case where a woman had 4 previous C-sections, I think, Jenna, had a wound vac, all of it, because I think that until people hear a case like that, or a case like the woman in the NICU that Jasmine, that kind of like opened up your eyes, they don't really understand that both disciplines, this is why we advocate for both disciplines, but especially occupational therapy, which you guys can probably tell more than me. You have to tell people, no, we're not working on getting you back to your job or work,
Yes.
Exactly right.
like I know you're not going to work right now. I mean, I know that the branding of occupational therapy is just a little bit confusing, but we advocate so hard for your profession to be in the room if one of us had to be in the room. And so Jenna, can you just like very just briefly just remind them of that case so that people listening can just hear how an occupational therapist would have responded in that situation?
Sure. And I have to admit it, what's kind of funny is at first when you started it off, you said, oh, I want Jenna to share this story about a time where a physician said that they don't need therapy. And my thought was, I have no idea which case you're referring to because I've had so many physicians tell me that they don't need therapy. But thank you for adding on the extra details there. So I did have this one patient that I was working with where we were still in the early phases of trying to get automatic orders. So we didn't have automatic orders yet. I was calling physicians after anyone who I saw had had a cesarean section. So this was one of those same cases, and I knew it was a repeat. I didn't know which number it was at that time. I just knew she had had one before, and I knew she had 4 children. And when I called, the physician just kind of made the statement that this is her 4th cesarean section. She knows what to do. I really don't see the point or the need. And it's all about how you frame it, right? And so I just kind of let him know some of the things that I would just offer to the patient, and that it would ultimately be her decision. I didn't, because that's their big sometimes fear, is that the patient's automatically going to get billed for this, and I don't want them to be charged. And well, let's leave it up to them. Let's see if they would want that. And so when I come in the room, it's completely dark, which I was not expecting. And um, the baby is under the, oh my goodness, those special lights. And she was so fearful to turn on any lights or to open her blinds because she truly didn't know if that was going to interfere with the lights that her baby needed. And she was scared to get out of bed. She was scared to do anything. She had not only did she have that fourth cesarean section, but she had a wound vac as well. And so she was scared. She said, "How am I supposed to move with this thing? I live on a second floor apartment. I only have stairs to get inside. There's no elevator." She not only did she have three other children, but the second youngest was only 1 year old. And so she wanted to still breastfeed the 1 year old, and now she had a newborn in addition to that. And so all of these things are starting to come about when I first opened that door. And I'm thinking, okay, the physician said she didn't need any therapy. So what I'm curious is, I'm a physical therapist by training. And so just with that background information, nothing further, I'm curious, what are some things going on in an occupational therapist's mind and how you would maybe proceed with that?
So it's funny. Sometimes I hear that, like, if doctors say they don't need therapy, I kind of take it as a challenge because I'm like, there's so many things that we touch on. I do think some of why our program has been successful is, one is we've been consistent, and we also are consistent with teaching our scope of practice for both PT and OT. So for an occupational therapist, when we do go in to see patients, we're very client driven. Like, we're making goals based on what is it that you want to do, like what is important to you. And I can tell you, all the patients that I've seen post the cesarean section, they've all been different, because I go in and one woman's, I'm in so much pain. Another woman is like, I haven't had a bowel movement. There's just so many different things. And I'm tailoring my session based on what is it that you need. One of the biggest, like, success stories I feel like I had was when I walked into the room. One mother was like, "Oh, all these, you're worried about me. This isn't about the baby." And I'm like, "Yeah, this is about you, because you're the one taking care of the baby. You had to take care of you first. So what is it what is important to you? Tell me about your home setup. What is it you're going to have to be able to do when you get home? Because our job is to get you back to your daily living, whatever is most important to you, and for you to function in your day-to-day life."
Mm-hmm. And Jenna, kind of to go on your story, what you were just talking about, a big thing with OT that we sometimes miss is the mental health aspect. And that's kind of maybe where I would start with, kind of what you were just saying, with the lighting, and it was dimmed. She wasn't educated on why, and I feel like once you know your why, your own anxiety, your own anxiousness can go down, and then you can start to focus on the physical. But if someone is so worried, they're not going to listen to anything you are saying. So it's going to go in one ear and it's going to go out the other. And then based on her response is how I'll keep tailoring the session. So
Thank you so much for that. And I think you really touched on such an excellent point by saying someone's sort of mental state, if they are not in a good place, what we kind of want them to do, at least from an evaluation standpoint, right? Because we are evaluating, that goes out the window. They're not going to want to do anything. And so I think you brought up such an excellent point of, where does the priority need to be? It needs to be, well, let's actually help this person in their mental state. So whether it's bringing down anxiety, whether it's helping them to just feel heard, sometimes that
mm-hmm.
can be very powerful.
Mm-hmm.
And then we can kind of go from there.
Yeah.
So thank you both for that.
Yeah. I actually had a patient who had a fetal demise, but she ended up giving birth in the same room that she had her previous C-section in. So let me backtrack. So the first C-section ended in a fetal demise, and the second one ended with birth. And so she was in that same room. And so I walked into that. That was not in any charting. That was not, no nursing gave me any, indication of what I was walking into. So that's what I had to deal with and help her to kind of. So I ended up doing mindfulness with her after she told me what was going on and just listening to her. So my session actually had nothing to do with any of the physical aspect on that day. And then I got her out of the room and we walked around the unit and we kind of talked while we're walking, so actually kind of doing two things at the same time, but just to get her out of the room because she hasn't been out of the room up until that point. And then honestly, she started talking about her angel, and that helped her cope too, and talking about her new blessing. So kind of just bringing it all together.
I think that's incredibly powerful. I wanted you guys to really just go through that, especially with Jenna's story, because she purposely kind of left out some big pieces of information that I wanted to know, because on a bigger scale, I knew what we wanted to do in that hospital system was the same thing that we left the other hospital system in that same state. We knew we wanted every mom, especially after C-section, anything like any high degree perennial tear, anything that would impact their function, their mental health. We knew we wanted to give them access to occupational physical therapists, but we didn't really know how to necessarily put these pieces together in a new system. It wasn't like several hospitals in the one system, right, that we're talking about with you all today. It was a completely different state, different hospital. And that mom was a Black woman, which was very important because this was Colorado, not Houston, Texas. Houston has, I mean, just Texas in general has one of the largest Black populations in the United States as a state.
Houston, definitely.
Right. And then Colorado, right, which I think where we are now, at least where that hospital was, even though it was the largest birthing center in the state of Colorado, it still had, I think, less than a 10% or less than a 5% Black population rate. And so here was this woman who actually was going home to no mattress. And one of the quotes that we, use from just this amazing therapist that, advocates for moms and maternal mental health and doing a lot of remote monitoring is, well, what's the point of actually teaching someone the log roll if they don't have a bed to return to?
Yeah.
Right. And so I wanted to just bring that back to you because a lot of people, when they hear you, Jasmine, say you gave one talk to your executive team, they asked you to do this in 12 hospitals, people get overwhelmed. So I needed to take us back to, okay, well, how is this therapist with patients in the room? How is Rachel Lewis, how is Jasmine Dockett with their patients one-on-one so that they could see that the same approach that you use with your patients, you're using with your team, you're using with your colleagues, you're using with your administration, you're getting to the why of what we do. When you do that to the executives, you can really get the buy-in. And that's where a lot of people just kind of like, just forget. Because you're not getting the buy-in for this big program and the revenue and the reimbursement and the insurance, and you're getting the buy-in for treating a human being like a human being. It's treating them with dignity. Right?
Yeah.
And so my question to you is, did you have to do a lot of negotiating, navigating around revenue and reimbursement when you guys were starting your program?
Actually, no, we didn't. So after we did the executive team, then that's when we went to the OBs and all of that. But that was still the same approach. They needed to know the why first, and then we had smaller talks of kind of like the insurance topic once they were in reimbursement, once they were more on board. But we didn't get a lot of pushback on that aspect, and more was just like, how is this going to benefit? You know what I mean? And you have to really break down what an occupational therapist and what a physical therapist will do and how that's just going to further improve the work they've already done, So that's kind of where you have to start. Because I feel like if you're starting on the reimbursement aspect, you didn't even get them on their why. You didn't even get in the door yet. So if you're going with that standpoint, you're talking to the wrong people at that time. Like that comes, but you just kind of take a little bit with each meeting that you have. So it kind of just grew on top of each other.
So you didn't lead with money, is what my take.
I didn't really understand that part. So
yeah, and me back then either. Yeah, kind of to jump on what Jasmine said, we had to explain the why and our role. And once we explained our role, because we are professionals and experts at what we do. So once they heard, this is what we're looking at, because you don't usually equate a occupational therapist with mental health, but that's where our profession started. So we are experts in talking about that, and then being able to get a patient to engage in their daily activities through addressing mental health. So this is when we start explaining these things to doctors, they were understanding. And then the next step is when we go to speak with nurses on the floor, we are explaining we're not here to disrupt your flow. We're here to add to the patient's hospital stay, make them more mobile, make them get up and go to the bathroom so they're able to have a bowel movement, reduce their pain. And this is buy-in. They care about their patients as well. And we're here, we're not taking anything away from you. We're adding to it.
Can I just say something? That was fire. Just I've never heard it phrased like that. And that is, I think, the best way to say it is that we are not taking anything away. We are adding to that. Oh, I got chills when you said it. I love that.
Yeah, but I do think, it's what brought us in. I feel like one, also just leading with being passionate about the profession and being compassionate towards the patients. I feel like they couldn't tell us no anyway.
Yeah.
What was the overall response from your patients? If you can even if there's a story, I know we led with the mom in the NICU and then just other examples, but even in your teachings, did you bring in cases and patient examples when you were teaching and training the therapists around the different hospitals?
Yeah. Oh, actually, which is kind of funny. And the very last hospital we had, they did choose one patient to for me to teach the therapist on, before I even got there. And she was a rehab liaison. So she was like, I want occupational therapy, physical therapy on these floors. And she actually was the one who advocated for us to even be there before they even asked her if it was okay for me to come in there and kind of teach the therapist of what's going on. And so I didn't have to do much talking. She was just like, this needs to happen. And so that actually gave buy-in for those therapists and their hospital right away because of how enthusiastic she was and how grateful she was. And so that kind of helped them, have that buy-in with the nurses and to kind of get the road going. The responses have been really great, mostly from the moms that have had C-sections previously. The moms that are the first C-section, they don't really know what to expect. So, but they're on the younger side. They're like, oh, this is fine. Cool, thank you. But our moms that are 30 plus, they're definitely the ones that are like, wow, this is exactly what I needed.
You know what I find really interesting about what you just said, though, is that I don't know if you've ever experienced sort of pushback, but the most pushback I ever received was actually for those that it was a repeat cesarean, because the argument, at least from a physician standpoint, was that they've had this before, they know what to expect. And so, but it was easier to buy in if it was someone's first cesarean. It was easier for us to kind of get our foot in the door. But based on what you just said, you actually had more positive responses from individuals where it was their repeat. So they had it before. That's fascinating. Do you have anything about that you may want to share? I don't know, you may not have an exact quote, but what are just some things that they've, generally said?
It's more of like their experience. So if they've
Uh-huh.
had a C-section before, they're like, I never got this last time. Even a lot of people come back to our hospital for their second and third, because they know the hospital, and they've asked me like, was this here the last time I was here? And then I would kind of give my little spiel. I'd be like, oh, actually.
I love
um,
that.
but yeah, so it's been great.
Mhm.
Wonderful.
You get to
Wonderful.
actually now play the opposite role of us because now you've trained both disciplines,
Mm-hmm.
right? Right?
Yes.
Mhm.
Physical therapists, you've trained physical therapists
Yeah.
and other occupational therapists to serve moms on this unit. What would you say in terms of just from that standpoint? Because to me, it's been incredibly challenging when occupational therapists know so much more than me. I'm just saying for me, for my, not that they know more than our profession, from me,
Just-
I'm just like, teaching you all was it's just been really humbling is that I'd rather just, put the mic around the room and just let the OTs talk. For your standpoint, how was it teaching both disciplines on what they need to know or what they knew already, giving them the confidence, answering their questions? How was that just this past year that you've been training?
So definitely, okay, so the physical therapy aspect of it, I'm not a physical therapist, so same thing. But I kind of just kind of took the point is that we are all acute care therapists. We've all been dealing with, different populations. This is just another population, and we just need to get a little bit more educated on the background of it. And so nobody knew like really the background of everything. You know what I mean? Even if you were pregnant before, you don't know necessarily the medical aspect or the scientific aspect of what's going on in your body and what happens after. So, talking about that and being educated in that aspect for myself, I felt confident in being able to relay that information to the PTs and also the OTs. Because at the end of the day, I'm not trying to be a physical therapist. I'm just trying to, just say this is another population, and you guys can add your little gravy, and then OTs, we add our little gravy, and there you go.
So are you saying, Jasmine, that your the framework you kind of used was really about this might seem like a new population, so let's talk about just some background
Mm,
information that maybe you're not aware of, and go. You know
yes.
what's in your scope, go ahead and do it. You know what's in your scope, go ahead and do it,
Yes.
right?
I think
Mhm.
it's
Love
more of
it.
just like
Love
giving the
it.
confidence on the person that you're dealing with. It's just kind of like having a stroke patient for your first time. Okay, what's the why and why are you doing it? And then you add it to your OT or PT brain of what you can help to benefit that patient.
Mhm.
And then I felt like once they felt that, then it's just like, another population.
Mhm.
So
That's
That's
amazing.
right.
I want to kind of like bring this full circle because now a lot of the questions are around evidence-based practice. Like, where are we going to now? Um, Either, collect data to show there's a difference that occupational therapists, that physical therapists are making on the maternity unit before hospital discharge. Where's the
mhm.
evidence for that? Where's the data? Where are the outcome measures that we're using? What's the results in long-term, impact to moms? And so now that you have this, system-wide, hospital-wide, therapists are doing it, what do you foresee as, being probably barriers or challenges to now, getting this disseminated to other health systems? What do you see, or the opportunities? What are opportunities that you see?
Um, well,
I don't know.
well, I do think it's a great opportunity to continue to grow. Like right now, we're in postpartum, but for getting into antepartum, like that is
Oh,
not something we're in right now, but it's just continued growth. Um, and that's
Yeah.
what I foresee, and just I'm excited about having those possibilities.
Yeah. The other question I have gotten is
Mhm.
discharge. So
Mhm.
home health wise, that or outpatient or whatever. So that
Mhm.
part is something to start to consider more too, because we are seeing these patients probably only once eval and maybe twice, you know, because of their short stay. But that aftercare is another aspect that can really get evaluated on.
And we talk a lot about social determinants of health and that just those very like unique situations where there might be a single mom or they might have a toddler at home and then now have this newborn. In Jenna's case, that mom, and correct me if I'm wrong, Jenna, she had 4 C-sections, 4 children, then the newborn, and then she was expected to return to work at Domino's within 2 weeks.
2 weeks.
Wow.
Right. No mattress at home. She had just moved from one state to Colorado where she delivered and just basically had, little furniture, if anything, but definitely she had a mattress on the ground, right? An air mattress.
She had an air mattress,
An
yes.
air mattress, right? So imagine just getting up from an air mattress on the floor after she would be going home with a wound vac. And so we think about these like cases that we encountered in our practice and we think, my goodness, first of all, let's make this sustainable. But then second of all, we'll need funding, we'll need grants, we'll need backing for this research so that we know that we're not going to go away, that this is not going to just end with you, Jasmine. And thankfully you trained across hospitals, so you made sure of that.
Yeah.
Right. But those are the stories that I kind of after is that, do you see the community at large, around these hospitals actually advocating and saying, no, I want to make sure I have an occupational therapist and physical therapist, like you mentioned, is being done. Do you see more of that in the future where moms are going to come in and these services?
100%. Our media team now is getting on board. So that's a big aspect. It's kind of weird. I see my face on the TVs around the hospital.
How funny.
Give us a scoop on that. Yeah.
So it actually came from one of the patients advocating. And so the media team kind of takes good stories, and so then they kind of wanted to know more about the postpartum program. So then they had myself and the manager at the time kind of give a snippet on what OT and PT can provide with postpartum moms. And it's a TV that is right outside of the postpartum unit. So everyone sees it as they walk in. And so now they kind of get an indication of like what we're doing without us having to say it. So that's one aspect. And then we also have a flyer that Rachel made that is hopefully going to go it's hospital wide too. So
Rachel, and I saw that flyer and I said, hello. Can I like get a copy of that template? Can we just like
of course you can.
So professionally done. And this is where I want to kind of like now wrap with this, is that therapists who are interested in starting these programs on the maternity unit, I personally, because we've now worked with over 86 therapists, Jenna, across the United States, from we're almost covering. We even had Alaska recently, so we haven't had anyone in Hawaii, but almost every state we've trained therapists in. And what we're finding is a recurring theme that they're moving into leadership positions faster than, and they're practicing years and years and years of therapists. They're moving into leadership teams because of starting rehab services on the maternity unit. And so if you could maybe end with that, or do you see that there's going to be more leadership opportunities if therapists are taking more of an investment approach, if you will? There's going to be some investments. I mean, you definitely had to put in the work, put in the time. Rachel, you were making, obviously, pamphlets and things and having to put the PowerPoint together and speak and work on those weaker muscles that we're not used to doing if we're not right. But the leadership opportunities, can you just speak to that for just the audience to just realize that the leadership opportunities are probably unlike anything that I've ever seen on other units or other initiatives?
Yeah, I do think there's going to be a multitude of leadership opportunities that come with continued growth. I do think the one barrier that I probably would say that it's something that we always will continue to work on. I remember when I was in school, they let me know as an occupational therapist that you will always be advocating for your profession. So that is something that I try to make daily, especially becoming a leader, is I'm advocating not for only occupational therapy, for physical therapy as well, but as an occupational therapy, I'm advocating for these services for people because of the things that we do that other people do not know. So I do think that's one of the ways that I was able to move into leadership, was to continue to advocate for the profession, the importance of having multiple PT, OT, and speech therapies. And I think if people are just continuing to be, again, I've said passionate so much, but if you're passionate about providing these services and what you do and you can provide for the community, I feel like there's going to be a multitude of opportunities to continue to grow.
Yeah. I also think it just kind of gets you outside of yourself, you know, speaking for myself, even doing this 2 years and now would, I would be freaking out. So,
she's now our public speaker. She speaks all the time. She was so nervous. Yeah, she speaks all the time. She was so nervous in the beginning and now she just does it all the time.
Public speaking was not my thing, but, you know, not at all. But after opportunity after opportunity, you kind of just get more in the flow of it, and then you kind of start to like certain things that you never thought you would have liked. So it's just, you know, that's this thing about opportunity. You get to see other aspects of yourself, you know.
Jasmine, I can't wait for your TED Talk. Both of you on the red carpet for sure. And please advocate away. I know that in your profession, AOTA, there is an AOT we met who like organizes TED events or something. So he's
we can give him your name.
Opportunity.
That's right.
So long, I believe. And so anyway, like that's just the opportunities are just knocking. I think public speaking and just professional representation, you two are doing it. You're my hero for sure. I mean, you've just surpassed really anything that I could just say we've done on a system-wide level like this. It's just incredible. And the speed that you did it at has just been like
it's mind-blowing.
Yeah.
It kind of has been.
Yeah.
Even for you.
We have good people and good support.
Yeah. Because now we also have automatic orders on OT and PT. Wow. So we were having to do what you were saying, Jenna, is call every morning. And that kind of got physicians annoyed. So, but yeah, so now we have automatic orders. So, in all the hospitals. So it's great.
And can I just ask, OT and PT. And then just to clarify, and I apologize if this was said earlier, but is this for anyone after a cesarean section? Is this after any delivery?
Just any, right now, just cesarean sections. So all cesarean sections have an automatic order. And then now that we've gotten that, we can try to go into the other aspects of things.
All right.
I will say though, what it has opened up a lot of doors, because I do think like for our patients, they have seen a lot of physical therapists after, we'll say, like a tear. So this has opened up there's therapy coming down for this and that and this. So it's opened up so many more opportunities for PT and OT coming down there.
Wait, what do you mean? Can you just clarify? Are you saying this opened up other opportunities like a high degree tear, like you said?
Yes, because physical therapy was already seeing those types of patients. So now it's once you get down there, the nurses and physicians, everyone's seeing like, oh, OT and PT do more than just these tears. I'm going to go ahead and put in an order. I'm going to go ahead and call them. So it's kind of prompting them to call us because they know what our scope is and that it's now outside of just we were doing so many different things that they're seeking us. And that's how I feel like I know that we're making it.
Yes.
Wow. Would you ever consider getting published, like writing up any of, it could be a case report, a case study, or doing like a presentation at maybe your AOTA national conference? Just throwing out ideas.
Jasmine and I have already talked about it. We love AOTA. Okay. No, let me stop. We didn't get that far, but we do. We are supporters of AOTA, of course. So I do feel like it's an opportunity that we would definitely love to be a part of.
Okay. So it's on the table.
Starting there.
But it's okay. All right. All right.
We often like, and we don't mean to like, oh, what else are you gonna do? Like, you guys,
Right. You're not doing enough.
First of
What
all,
more are you gonna
you
do?
have already done, like, to just even say professional career wise, like to just put a check mark on just an impact, like you've done that, and more so. I think our excitement really is coming from probably our just want and desire to know what can we do to support you, or what can we do to even support other professionals knowing about this even more, because the big elephant in the room is that there's not enough of us to even just treat the C-sections alone.
Yeah.
Right? Jasmine, you opened up today saying that cesarean section is the most commonly performed surgery in the acute care hospital, was also in the country, and then in the world, when you're looking at major surgeries that are performed, is C-section worldwide. And so just with that surgery alone, 1.3 million in the United States, that exceeds almost hip and knee replacements combined.
Yes.
Always rushing to get orders, definitely seen for that patient population as OTs and PTs. And so that's kind of more of like, okay, well, what can we do to just support and just disseminate and distribute your work, or anything that you could foresee? What are there opportunities to help and to support what you're doing on a bigger scale?
Sorry, can you repeat that question?
For researchers who might be watching this, would you say that would actually be a help for you if research connected with
I know Rachel actually is a passionate about research and stuff like that. I think that's probably the biggest thing right now that we obviously lack, because it's new, and I feel like if you can have stuff to back up everything you're saying, because the feel goods are nice, but sometimes you're going to need to have that hard evidence. And then with the case studies and if you have multitudes of that, it's just going to further help other people when they are to give a presentation or to present or whatever, because you are going to be dealing with different people, and different people react to different things. So it's kind of being able to read the room that you're presenting in. But yeah, I do believe research is probably the best component that we could be implementing now.
Awesome. Yep, that does it for me. I feel like if there are people who are looking at this, watching this later, and they are pursuing their PhD, they have their PhD, they want to make a bigger impact in maternal health, this field is wide open, right? They're acute care therapists. Now you're disseminated automatic orders throughout all your hospital systems. This is a partnership opportunity. And so the times we're doing these interviews and things like that, we want to get to the meat and the potatoes of how all this came about. But now this is a next step, call to action. If you are interested in really expanding the evidence that your work is doing, here's an opportunity to potentially connect with you all and partner, on some studies or get grant funding or research.
Yes, 100%. Yeah. I agree.
Thank you both for your time. I mean, this was phenomenal. This was just exactly what we were hoping to just reconnect with you all 1 year later.
Yeah.
Can't thank you enough.
Can't believe it.
We can't thank you guys enough, because honestly, we had the idea, but like, you guys already did it and kind of just took what you told us a year and a half ago now, and kind of just went with our passion as well, and just went with that. So
Spreading the word.
You are doing amazing work, amazing things, and it's just so exciting to really get to see both of you, get to talk with both of you again, but then just to hear how successful everything has been it's just wonderful.
Well, you guys are wonderful.
Yeah, you are.
No, you. All right.
No, you.
Thanks, everyone. Bye.
All right. Thank you.